Hello and welcome to Researcher on Call, an interactive series by the Canadian Health Services Research Foundation. Researcher on Call brings together policymakers, healthcare executives, researchers, the public, and you to be a part of a dialogue about ways to improve healthcare for Canadians. And today's discussion focuses on achieving well-coordinated care, addressing cracks in the system. As background, Canadians have access to a range of healthcare services, but the transitions between these can often be disjointed, uncoordinated, and frankly complicated. These disconnects in care are frustrating for everyone, especially patients and caregivers, and for the frail elderly, for the disabled, or those who are chronically ill. Disconnects in care can also be detrimental to their health and costly to the healthcare system. So how can we ensure that patients move seamlessly from one point of care to another, and that they receive care that is high quality, reflects their needs and values, while not costing more than it needs to? This session of Researcher on Call examines the role of local, regional, and government actors in pulling the system together, what we often call the integration of health services. To offer better care that brings about better patient outcomes, actors at multiple levels must come together to define and realize a shared vision of what they need to accomplish to achieve, operate, and manage a system of integrated care. So joining us to talk about this shared value is Shirley Sharkey, President and CEO of St. Elizabeth Healthcare, and an adjunct professor at the University of Toronto. We also have on the line Mary Cardos-Burton. Mary is the project manager of the Integrated Client Care Project, and she's based at the Ontario Association of Community Care Access Centres. The Integrated Client Care Project that Mary's going to tell us about is underway and studies the process and impact of reorganizing care around patients' needs, with the broader goal of redesigning Ontario's healthcare system to dramatically improve the value of care, where value is the patient's outcomes for the total cost of care for their condition. On the line today, we welcome over 130 organizations who are registered, and we have representation from across the country. Today's call begins with a presentation from each Shirley and Mary, and then I'll open up the lines for a question and answer period where I'll take questions from you, our audience. So without further ado, I'm going to hand the mic over to Shirley Sharkey.
Hello, everyone. It's a real pleasure to be presenting to you. What we will do is give you some specific examples as it relates to coordinating care and integration. I'll spend some time talking really more at a macro level. What are some of the issues to deal with readiness? And then also maybe be a bit provocative to say that the solutions we have to come up with probably are broader than all of us in the health system, and will include the community and probably society at large to really get to the types of improvements and benefits we're looking for. So if I could move to the next slide. When we look at creating shared value as a group of players in the healthcare system, what does value really mean? And why are there such pressures as we want to look at integrating care, coordinating care? Well, certainly I think that consumers' expectations are driving some of that push for value, transparency, accountability, a competitive environment we're in, the complex decision-making, the technologies are changing, and the autonomy of our workforce that is certainly more knowledgeable and ever increasing in their learning needs. Value is typically defined as benefits, and that's an unusual word because typically many times in healthcare we look at what are the activities, but it's benefits that are delivered either by organizations or in a combination of organizations that are best positioned to achieve the most impact for the least cost. And we typically have looked at the most impact by being the best clinical outcomes, in addition to the client and family's satisfaction of that care or information or service that has been provided over the least cost. Typically we look at improving quality to allow this to happen, or also ensuring that we have a workforce that is focused and aligned with the initiatives we're looking at. What's critical when we look at, I think, integration and coordination is the starting point as we're trying to determine what that value is or what the shared value is from all of the players in the system. And I think historically, many of our coordinating and integrative examples have started primarily from the acute care and looking at how do we improve that system so that people either move out of the hospital quicker or emergency rooms work more effectively. My challenge would be that typically with hospitals and home care costs, it usually is impacting only about 5% of Ontario's population. Imagine if, in fact, we could look at more and broader views of how to coordinate care by what's happening with the 95% of the other population that remains in the community, that is healthy, and that is able to cope in that environment. Particularly with seniors, for example, we know that 75% primarily are living in their homes and actually rank that their health is pretty good. Imagine if we spent as much time trying to look at how to redesign things that keep them healthy and well versus all of the time and energy that we spend with that 5%. Certainly those resources are very costly, but it is only impacting 5% of the population. So as we look at a number of these initiatives, it's, I think, imperative for us to step back a bit and see if we can redesign them in a different way and a different starting point. Next area I wanted to look at is the readiness, and there's really two key components that I'll be addressing. This is people, dealing with both leadership and the workforce, and then secondly, evidence and innovation. Why leadership is so critical? Because there are so many players. It's leadership in various places, various organizations, various structures, and leadership in every level of those various organizations. It's fundamental so that we can understand what are the roles, what are the performance expectations, how best we can execute, and then how we can get those results out front and center. The other area when we look at people and talent is the frontline workforce. And we know that many of the changes that need to happen with coordinated care or integrated care, the solutions rest with the workforce at the frontline level. And actually it was interesting at the latest CEO forum in Montreal when Helen Bevan from the National Health, the NHS in UK was speaking, really identified that the solutions we're going to get for improvement in the system rest right at the front line with, in fact, the health professionals. And we have to empower them, engage them with the tools to be successful. And one of the key things to really make sure that they have the tools and the processes to move forward, deal with evidence and what I would say, unleashing innovation. And these are real cultural changes that I think are necessary for all of our organizations as we move forward in these forms of integrative approaches. And they take time and resources. And it's not just about evidence as it relates to best practice, but evidence for how we make decision making. In addition to innovation, just from my perspective at St. Elizabeth, we've been about 10 years creating processes, systems, and cultural changes that allow us to really deal with idea generation, dealing with risk, and all of those factors, so that when we move into creating new programs and services and coordination, you bring evidence and innovation kind of unconsciously to the process. If I could have the next slide. If I could have the next slide.
Hi, Shirley. It looks like we're having technical difficulties, so please continue, and we can circulate the slides if we can't resolve the issue to participants.
Okay, that's great. I wanted to move next into some specifics with St. Elizabeth Healthcare and some of the examples, looking at both the starting point that I have referred to and then actually some examples where we have really been able to see shared value with all of the players involved in integrated care. just from St. Elizabeth's point of view, just so you have a sense of our size and magnitude of what we are involved in, you know, throughout the country in some way, shape, or form, we're involved in community care or home care services, which allows us the privilege of really having a different starting point when we look at new programs or new ways to bundle services. And I think that this has been augmented with also our overall vision and direction and starting point when we look at changes. Our vision is really to honor the human face of healthcare, which is an interesting beginning point to look at the potential of people. And it brings me back to my initial statements where our starting point, where we begin to coordinate services and to deal with new approaches for healthcare improvement. If we can start with the strengths of people, there may be a very interesting outcome to how we move forward. So I think the vision of every organization or health authority or government initiative, I think it's fundamental. It has to begin from that premise versus sometimes when we're looking at cost cutting or simply sustaining the system that exists today without looking at how can we actually improve it. So just briefly with some examples of how we, I think, have created some interesting shared value, which means actually expanding on the values that each of the individual players were involved in. The first project I wanted to talk about was our Wait Times Guaranteed pilot project, and this was a partnership with the Assembly of Manitoba Chiefs, where we developed and delivered an effective healthcare approach for clients with diabetic foot ulcers. And we did this within the context of creating a Wait Times Guaranteed program. What was really interesting with this initiative, it was really what I would call pilot on the run, research on the run, learning on the run, and delivery. But I just give it to you as an example of how you need to have innovation, evidence, and moving forward as we really look at trying to coordinate services. The next example is just to provide an idea that coordination and integration isn't just about care. And our Seniors Health Research Transfer Network is an interesting project which is about bringing together diverse membership and helping to disseminate knowledge for seniors with serious mental health and addiction problems. And this uses a variety of innovative approaches to ensure that we can get the kind of coordination and reduce the duplication through knowledge exchange and service innovation. And the last one, and I'll stop there because Mary will be then moving into the Integrated Client Care Project, but the last one is Smooth Transition. And this is your more typical integrated project or coordination of care to really help seniors who are being discharged from the hospital. And Smooth Transition, that's been funded by the Northwest LHIN Local Health Integration Network here in Ontario, is really about fast, responsive, and flexible services for seniors who are being discharged. I give this as an example because many of the services at the very beginning upon discharge were not our traditional health care services, but in fact transportation services to get them home, medication pickup at the pharmacy, and receiving light housekeeping to prepare the house for them to, in fact, come back home from the time they've been in the hospital. And it's been an interesting initiative to see how that's been effective. So I'm going to just end by saying I hope that I've provided a few examples to look at coordination and some positive results, giving you some of the readiness factors that are critical, and just end with that it certainly takes us all, I think, as professionals, as systems, and society at large, to collectively reimagine our understanding of the access points and the experiences we can have in healthcare. I'm going to end there, and I'm going to turn it over to you, Mary.
Thank you very much, Shirley, and thank you to all of you for being with us this afternoon. I'm very pleased to be talking to you about the Integrated Client Care Project. We call our project From Theory to Practice, and I hope we persuade you that that, in fact, is what we're trying to do. In terms of the case for change, the Burning Platform did come from the government of Ontario with at the urging of many who felt that that change needed to happen. Our value proposition, and Shirley talked about value earlier, is that patient-client health outcomes with an end goal of healthier Ontarians, the total cost of care, and sustainable health expenditures. One of the things that we had done was establish this. First of all, I should say this started about 2 years ago. There was a shared vision established amongst the Ministry of Health and Long-Term Care, the Association of Community Care Access Centres. For those of you who are not in Ontario, that is the organization which organizes home care through a series of providers, and the Rotman School of Management. So 3 became sponsors for the project. In talking to people, and it started out as a project, in talking to people, many have given us the feedback that it has potential for success because you have the policy and the evaluative component from the ministry. You have the execution from an organization, the Community Care, the Association for Access Centres, and you have the opportunity for education and publishing through Rotman. So it is an innovative project to test and explore the opportunities for change, starting as a home care as a potential hub. And Shirley mentioned earlier, many of these projects that we do start with the acute care system. So for us, this is very innovative to start with home care. The thrust is organizing around client needs based on groupings. And the 4 that we've identified are wound care, palliative care, frail seniors, medically complex children. It's based on the work, although we've made changes since, it is based on Michael Porter's work in terms of principles for achieving value-based care in his book, Redefining Healthcare. So what was the approach that we used? This is a multi-year initiative. We started about 2 years ago with probably 3 lines written down and kind of a concept, and then Michael Porter's work to support us and had to make it a reality. In terms of what made it different, we went out to our organizations, our community care access centers, and to our providers and said, who is interested in working with us on this in terms of testing to change the system? I think that's an important point because in order to do something like this, you need volunteers who are prepared to make a commitment. There was no extra money provided to either of the organizations. Our approach was to use a quality improvement method. Shirley mentioned the frontline workers earlier, involving frontline workers and the senior leadership at both the purchaser and provider level. The quality improvement people who worked with us said they have never done it in this kind of model before, where you had a purchaser-provider relationship, which obviously even has different dynamics sitting in the room together. So I think that it was quite innovative. In terms of continuous improvement, we looked at all bottlenecks and redundancies and moved toward an outcomes-based approach for clinical and process measurement to improve our capacity. It's been 2 years. We started wound care last year, but we took about 6 months in terms of exhaustive literature reviews. So when you have a concept, you have to figure out what it is that you're going to do. So we looked at the integration component and looked at system, organizational, and clinical, plus we also looked at different ways in terms of horizontal and vertical. We decided that it was a series of interventions that make a difference, not just one, and we relied heavily on the work of Margaret McAdam, Marcus Hollander, Dennis Codner in particular, but others. So in terms of what we came up with, what would make a difference? We felt that if you changed the case management and had a better navigation system for clients and the system, that would make a difference. That involved looking at the roles and it does involve looking at the roles of the purchaser provider. It looks at the roles in terms of monitoring outcomes, and it looks at the responsibility and accountability for clinical care. In terms of coordinated and shared multidisciplinary assessment, what we're looking for is making a sharing of information, even if it's manual and not using the technology we would like to do, but it's really to get at the point of clients not having to tell their story twice. The integrated clinical service teams focusing on accountability for clinical coordination. We're testing out concepts such as lead provider and looking at the accountability mechanisms that I mentioned earlier in that, as well as different interprofessional teams and shared care teams in our groupings. In terms of adoption and agreement of best practices, that obviously is certainly critical, but added to that, we're looking at evidence-based design, which is actually using clients and families. It's based on the model that the National Health Service in the UK is using, so we're trying that out with families at the table, and we're also including an alternative reimbursement model, which is based on outcomes and rewards innovation. So where are we at? When we started the wound care, as I mentioned, it's been since April 2009. It's 4 sites put up their hand, and they're working with us, as well as 3 provider organizations. 2 types of wounds were chosen to ensure that we had a focus, but the plan would be to then extend what we've done to all kinds of wounds. The quality improvement process had helped us with an end-to-end process where we took the initial referral to the discharge point and helped us identify products that could be used across all CCACs and providers at different points in time. The different thing about this, though, is while we're doing wound care, we're also doing it's continuous learning, so we're also doing palliative care at the same time, which we're just starting, and we have 6 sites interested in that. Our palliative care approach is a more system-wide approach than wound care. So how will we know that we're successful? I think one of the things that I haven't mentioned is that one of the differences in terms of what we're doing, we're using impact and assessment and evaluation at the start of the process rather than at the end. Many projects that we've all been on have an approach that suggests they'll evaluate at the end and see how successful they are. We're trying to work with researchers and evaluators at the start to help us in terms of the design, and then have critical trigger points throughout the way. The key measures of success are some that you'll mainly be familiar with. One thing I would point out is that while everyone would hope for reduced costs, what we're really looking for is better value for the money that we do spend. I'll close now on just some lessons learned. First of all, this project is very complicated, complex. We still have some people saying, now, what is it trying to do? So it is hard to get a handle on sometimes because we're doing wound care, palliative care, and also integrating at the same time. But these are some of our lessons learned. It's important to keep the focus on the client. That is what this is about. This must be your compass. We found that because of the complexity, we get so involved in some process discussions, but you have to keep asking yourself, focus on the client, because some of our processes, if they are disrespectful to clients, then we need to change them. It takes the courage to admit that processes aren't as efficient. Every organization we're working with on the wound care said they were absolutely doing best practice. I think that they would all now say that they could find improvements to their best practice. To do this has taken way more time than I think any of the parties thought. Making change is difficult, but particularly when it's complicated and complex. The measurement of outcomes and identifying clinical outcomes as well as process outcomes, which we've done both of, has also been particularly difficult as well. making change at a system level, but making sure that there is local variation has presented some challenges. This is a system-wide project with a commitment from a broader level than just us, but then when you do that, getting the local buy-in sometimes can be more difficult. Our terminology, when we talk about care plans, care paths, etc., it was very unusual to find that we were using language that was the same but talking about completely different things. The trust needed, the creativity needed, and for removal of barriers to innovation. Part of what we are doing, we are testing innovative, and we are doing things that hadn't been done before, but some natural questions come up in terms of how do you pay for them. It's using the creativity. But the final point is the showing leadership, and I think I just want to reiterate Shirley's point in terms of that leadership comes at government levels, the execution level, at the academic levels, but it comes from the frontline levels as well because they help us with the innovations and solutions to some of the problems we're trying to tackle. Thank you very much.
Thank you, Shirley and Mary. I want you to know, too, that participants were actually able to see your slides, although we were advancing them here. We're now going to take questions from participants, and there's 80 organizations online at this moment, and I know from looking through the list that many of them are not shy, and there's two ways that they can pose a question. They can ask their question verbally by pressing *1 on their touch-tone telephone, or they can ask a question electronically. So for folks on the line, please use the questions box. It's located on your control panel as illustrated on the slide. And I'd ask that when you ask a question that you please identify to whom the question is addressed, and please try to ask only one question at a time. I also want to remind participants that these PowerPoint slides are currently available on the CHSRF website, www.chsrf.ca. I'm going to go ahead and pose the first question here as we check in with our operator. Shirley, you mentioned something I thought was really important, and you referenced the February 16th CEO Forum that CHSRF hosted with our partners, and you talked about the solution to improving the transitions in care really resting at the front line with healthcare professionals, but that leaders need to empower healthcare professionals with tools to be successful. Can you tell us a little bit about what kind of system leadership it takes to do that?
Well, I think really what I'm referring to is, I think, a sense of risk-taking, which is so unusual. I mean, that language we typically don't even use in the health environment. But it's a combination of risk-taking, commitment, engagement, and clarity, where we really get everyone to understand the goal, what we're trying to accomplish, from really clients having the best outcome and being incredibly satisfied with the kinds of care and services that they're providing. And then really free things up, unleash things. I found with Helen's presentation with the NHS, she really talked about how previously they spent a lot of time thinking about structures and compliance and monitoring, and started to realize that in order to get the gains with such kind of independent knowledge workers, mobile clinicians, it is about getting commitment from health professionals versus trying to direct and through structures make it happen.
Thank you. And Mary, from your perspective with the Integrated Client Care Project, what's your take on this? I mean, you said something really fundamental, I thought, that, look, this project didn't take new funds. It was sort of a question was posed around how can we improve transitions, and really asking for a show of hands. So there's a real leadership, I think, that's demonstrated there. But in terms of really empowering the frontline professionals to have the tools to really address these transitions and improve the integration of the system, what's been the leadership that you've seen through this project?
I think the leadership has come from the parties who are organized, who have put up their hands and volunteered for this. Obviously, there's a commitment sort of at all levels that I mentioned, but it's been really, really fascinating to see the front line participating. So we have education sessions. The front line is there with the executive sponsors, and what's really been encouraging is their willingness to speak up when they're not only the people who give them contracts, if it's at the provider level, are also sitting there, but it's also their bosses are at the same. So having those people at the same table has been a real eye-opener in terms of trust and having the same conversations and having the same education sessions provided to them. So it's been really fascinating. We have them also present, rather than the senior people present in terms of what's going on and what are the innovations and what are they doing that's different. The front line actually does it. So that's been really, really helpful. So those are some of the learnings that we've seen.
Thank you. I do have a question, actually, and this is for Mary again, from Sue, who's posed the question through the webinar. She asks, Mary, can you define navigator that you spoke about in terms of case management and system community navigation?
Okay, we have a concept in Ontario which we have looked at having the community care access centers be system navigators, and that the intention there is to have a source for clients to actually call who can help them work their way through the system, which is more than just home care. It could also be a social support system. So that's what we mean when we say system navigator. But I think there's also one of the things we're finding is that there are probably circumstances where for some client populations there might even be a need to have more of a personal health navigator as well. And I mean, we are testing our concepts and we are looking at different things. The end result of the work that we're doing after a multi-year period is actually looking at, first we'll implement what's successful, assuming we get agreement on it, but in terms of some significant policy changes, those would go back to government and perhaps have an impact on the policies for the future. So I hope that helps. It really is the system navigator that can help work their way through the system and help clients get in touch with other parts.
Excellent. Thank you. I'm going to ask our operator, Yvette, if there's any questions at this time through the phone line. Yvette?
Yes, we do. We have a question from the line of Judy Bigham from Nova Scotia Department of Health. Please go ahead.
Gail Sloan, actually. I'm here with Judy and Heather. I have a question around within the different models of primary health care in Ontario, understanding the LHINs and the SINs and all those other things. How does this engage with your project in terms of primary health care at the individual provider level, say fee-for-service docs versus folks in the family health care teams? Or do they?
Sorry, is that for me?
Whomever. I'm interested in how you're engaging with the various primary health care providers.
Okay. Shirley, I'll start then, and
Great.
then you can jump in. In terms of the primary health teams, we are engaging with them. In fact, we're doing different things, such as we've created charts. It seems like a small example, but the nurses in the sites are taking those charts. Not the nurses. The individual clients are taking their charts to the doctors. We've actually had feedback where the doctors are writing back and saying that the nurses now know the size of the wounds and how impressed they are. So we're engaging them from that perspective. We're also engaging representatives from the family health teams. We have expert panels whenever we start our groupings. But I think the most significant one will be we're now going to be launching palliative care, and we certainly do involve the physicians in that. They'll be having a seat at the table with our broader integration that our local health integration networks will be leading. So it's home care, and we started with the CCACs for wound care, but when we move to palliative, it certainly will be primary care, long-term care, hospice, a whole bunch of other groupings at the table, and that's where primary care gets involved. As well, we certainly have a lot of initiatives where we encourage linkages with the CCAC case coordinators with the family health teams.
Great, thank you very much.
Our next question comes from the line of Sukong Zhu from the University of Montreal. Please go ahead.
Yes. I have a question to Marie Cardos. Marie?
Yes?
My question is, in her project, how many families were involved in her project, and which kind of family was changed, which kind of family was difficult? Because she mentioned some is very complicated and is very difficult, and so I wanted to know which kind service is very difficult, which is more easier, and how many families involved in her project.
Are you asking me how many families are involved?
Yeah, involved, and because she said the some family is better than get better results than the control group. That means I wonder how many the sample size, and which group people is easier for in this project, and which group people is more difficult. I want to know some context information that involved in her project.
Okay, well, let me start to give you some information. So for one thing, we were encouraged to start small. So we've got two kinds of wounds, the venous leg ulcer and the diabetic foot ulcer. We have 600 clients involved in our project. And each of our 4 sites then includes families when they're having discussions. So these are actual clients. They bring them in and talk to them about what is it that actually could improve what we're doing and what gets in the way. And for the palliative care, we will be having that. For the wound care, it's mainly the client who has the wound. For the palliative care, our plan is to involve the families with those people who are experiencing palliative care.
The only thing, too, I was going to add, Mary, is the approach with this initiative has actually been innovative on its own from a research point of view and from a study point of view. And that it's been more about, I think, Mary, you spoke to that, it's really a learning cycle of how we're coming up with ideas and then actually, thinking about how do we implement them, then, evaluating at the beginning and middle and end. And it is a very different approach to kind of learning and researching and changing and understanding kind of all simultaneously through a learning cycle versus what would be more a traditional research approach to this pilot.
Right. Thank you, Shirley. Those are some of the things that do make it more complicated than complex.
Now, Shirley, I have another question that comes from the webinar from Cal Martell. Yes, you mentioned the importance of empowering frontline staff to create a culture of innovation, and healthcare has traditionally been a very hierarchical culture. So what advice do you have to change the culture to one of innovation?
Oh, yeah, that's about a 10-year answer. But it's a great question. We really have embraced a very different approach to innovation, starting from years ago what we called our idea factory and determining how to generate ideas from our frontline staff to how, and just as even I was explaining, a learning cycle of how we address coming up with new solutions and different ways of doing things, where we actually strategically identify how many mistakes we're going to make, how many solutions will not be the right ones, and we have targets for that in addition to the ones that are successful. So it's a whole organization-wide and a whole kind of philosophical approach to what you invest in, what you signal, what you support, and your tolerance for learning and mistakes and risk.
Okay. I want to remind callers or participants, rather, that if they want to pose a question, they just need to press *1 to get into the queue. And, of course, they can pose questions through the webinar portion as well. I do have another question here, and this one is from Mary. It comes from Elise from Health Canada. What is the client perception of the change in care model? So, for example, would a client with a chronic wound notice the change in care before and after integration?
One would hope that they would notice a change. I think they'll notice a change on a number of different levels. The attention that they're getting, the involvement that they would have, the looking at the whole person rather than just at the wound. And I think that's been one of the concerns that has been expressed. Hopefully the outcomes would be better from a clinical perspective. They would have information which they know in terms of going to the doctor, the example that I used before in terms of some of the changes. So from our perspective, if the client doesn't notice a change, then we perhaps are not as successful as we would like to be. So I'd say yes, and those would be some of the changes from a client perspective.
And Mary, Elise might be interested to know, too, that if she looks at some of the details around the milestones and highlights of the Integrated Client Care Project, that there is sort of a formative wound care implementation evaluation report that's been undertaken by an independent evaluation team. And so this is a project underway, so more information will be available as the project continues.
Yes, and there is also, we do have a website for the project which has an incredible amount of information on it. One of the things that we were asked to do, to be by the steering committee, which again is and maybe not unusual, but it's a little bit different. We have to be totally transparent. So everything that we have taken to a steering committee, and there are quarterly meetings, is on our website as well. Okay, so it's a lot of information and weaving through it. So we do have all the information there in terms of the costs, both from an acute perspective and from a home care perspective as well. And so every presentation is there, as well as a lot of other information, including the literature reviews that we've done, Q's and A's, whatever.
And you know what's been helpful in particular with this particular project, which was wound care, which was decided upon for a number of reasons, but probably the most significant, to measure the benefit, which is hopefully faster healing, is something that's more tangible. And that's also something to consider when we look at these initiatives, how to get the measures and the outcomes to be clear, succinct, and one or two versus how we typically have thousands. And that, to some extent, what was great about this particular project is you could really quantify and say the outcome is faster healing for the individual. I mean, in addition to many other facets with it, but it sometimes we get so complicated with how we're trying to look at outcomes that it's difficult to get your head around what we're really trying to accomplish.
Yeah. So, for example, for wound care, it truly is the reduction, and we've got the timelines identified. It's the length of stay. It's the adherence to the treatment plan. It is costing, It's the client and caregiver experience, and then the CCAC and the provider staff satisfaction. That's our mantra. That's what we're going by on this. And so, for each client grouping that we have, there will be quality indicator measurements that we will all agree to, and that's what it is.
Thank you very much. This has really been an excellent session, and I want to let participants know that we will be hosting our next session of Researcher on Call on March 31st at 12 noon Eastern Time, when we're going to be looking at innovations in pharmaceutical spending. More information will be available and registration details on CHSRF's website, www.chsrf.ca. I really want to extend a sincere thank you to Shirley and Mary. Thank you so much. Thank our audience, of course, for their participation today. And before you hang up, I want to let you know that you will be prompted to fill out an electronic survey, and that'll give us a sense of how many of you were actually listening in. We knew there were 80 organizations that came onto the call, and so we'll have a good sense then of how many, probably hundreds of you were listening into the call today. So that concludes today's Researcher on Call. Thank you again for joining us, and for CHSRF, I'm Jen Burma.